As part of the UP ACO, you're getting great support and important best practices shared amongst participating members. As you work to improve outcomes and processes and create a more sustainable future, the UP ACO is committed to improving the health outcomes of Medicare beneficiaries in Southeast Michigan by delivering the highest quality, most affordable care. Many ACO domains and measures have carried over from previous years. Some have been retired and others added. Despite these changes, the 4 domains of at-risk population, preventive health, care coordination, patient safety, and patient caregiver experience form the framework for the 33 ACO measures. This module is designed to keep you current on the measures and share best practices to help you be more successful. Let's get started. First up, your at-risk populations. These are your patients with 1 or more chronic conditions. About half of all American adults, or 117 million people, have 1 or more chronic condition, and 1 out of 4 adults has 2 or more. This adds up to 7 of the top 10 causes of death in the United States from chronic disease. So the definition of an at-risk patient is one that has a chronic condition, one that gets an out-of-range lab report, or someone who's had a procedure to rule out a chronic condition because they're at risk for developing it. While we want patients to manage their own conditions, we have to give them the right support. And this starts with 5 measures developed by the Medicare Shared Savings Program. By using screening tools, these 5 measures can be better monitored and controlled in our at-risk populations. The hope is to reduce acute events that create high use of services, adding up to high costs. These measures can also serve as a follow-up for patients recently discharged from the hospital, trying to manage their new or existing condition. Here are the things you need to be aware of. In adult diabetic patients, if their hemoglobin A1C is greater than 9%, they're missing the A1C value, or there's no testing recorded during that year, it's time to find out what's going on. They may not understand the value of the HbA1c test or feel that they can do anything about their diabetes. Educate them on the importance of getting the test done, do a test, and develop an action plan, which should include a follow-up appointment. Also, give them additional nutritional resources and counseling options. Be sure to document the plan in the medical record. The next measure is for those same diabetic patients. If they haven't had a retinal eye exam in the measurement year, or if they had a negative eye exam in the year prior to the measurement period, they need to visit the eye doctor. Chances are the eye exam isn't done in your office, so while you can recommend and refer, the patient might not see the other doctor. A great idea is to collaborate with eye professionals, schedule the appointment for the patient, and make sure you're on the receiving end of any reports or required follow-up plans. Tracking the patient is important. If you don't receive a result, follow up with a phone call or at their next office visit. The next measure involves adult patients with hypertension, diagnosed in the first 6 months of the measurement year or before. Document their blood pressure at each office visit. In fact, all patients that come into your office should have their blood pressure taken. If they fall into the pre-hypertension or hypertension category, talk to them about how hypertension can lead to diabetes, heart disease, and stroke. Give suggestions on diet and exercise, or refer them on to a dietitian. For both hypertensive and prehypertensive patients, be sure to clearly document any interactions you've had. This will satisfy the requirements for establishing a plan. Heart disease is the leading killer in the United States, so you'll want to keep a close eye on your heart patients. When it comes to the ischemic vascular disease population, the ones to watch are those older than 18 who've had a heart attack, bypass surgery, or angioplasty in the 12 months prior to the measurement period. Also, patients who've had an active diagnosis of IVD during the measurement period. These patients should be taking aspirin or antithrombotic therapy during the measurement period, and it should be documented. It's easy to forget to put aspirin therapy on a medication list because it's not a prescription, but make sure you do. For those patients not on medication, talk with them. Give them more information on the benefits and get them involved in a care management program. Best practices for IVD are to make sure you're reporting patient use of aspirin. It continues to present a challenge for the ACO because of inconsistent documentation of over-the-counter medications. The last at-risk measure involves depression. Any adult patient 18 years and older diagnosed with major depression and a patient health questionnaire score of greater than 9 should have a follow-up visit and a PHQ-9 retest. If that retest scores below a 5, the patient is considered in remission. Make sure you note that in their medical record. Depression screening requires a follow-up plan and re-screening at 12 months to document remission. For all of these measures, it's important to note the outcome in the patient's EMR. For those patients referred to specialists or care management programs, make their appointments for them so you know that it's done, and make sure you're included in the results. For our at-risk populations, it's critical that you follow up with any results they may be waiting on from your office and schedule follow-up appointments. There are lots of challenges to improving our at-risk populations. Knowing which patients have been discharged and for what reason, patient compliance, lack of patient understanding, patient no-shows, time management during an appointment, and dealing with multiple chronic conditions in one appointment. The best thing you can do is during each office visit, perform all regular screenings and tests such as blood pressure, HbA1c, and height and weight. Review your patient's medical history, review their medication, and follow up on any care management or counseling programs. And by establishing relationships with other care providers, you can really become a partner in the care of their chronic condition. It will save lives. The next domain to be mindful of is preventive health. Just by implementing preventive services, we can save 100,000 people each year. It's those things that seem like they won't make a big difference, but do. That's why the Centers for Medicare and Medicaid Services, CMS, has developed a set of 8 quality measures to help us lead the charge in preventive health and build a healthier community. Do you encourage your female patients between the ages of 50 and 74 to get a mammogram? Make sure you're thinking pink. CMS calls it preventive care and screening for breast cancer. What it means is that these women need to go in every 27 months. The exception to the rule, those who've had a bilateral or 2 unilateral mastectomies. Guidelines are looking for a documented mammogram report in your patient's registry or record. If you come across any that don't have one, call them up and get them in. Colorectal cancer is one of the leading causes of cancer deaths, but the good news is colorectal cancer deaths are on the decline. And a big shout out goes to you. You are getting more and more of your patients to come in for their recommended screenings between the ages of 50 and 75. Early detection is saving lives, and CMS is taking note. This measure is called colorectal cancer screening. Make sure when you're reviewing their chart that you see documentation of this screening. If not, tell your patients it's time they get screened. You can recommend a fecal occult blood test, a sigmoidoscopy, or colonoscopy. Cologuard does satisfy the measure if performed in the measurement year or the 2 years prior. For those patients not in your office, search your database for those that haven't gotten screened. Give them a jingle. That call could save their lives. The first preventive care and screening measure is for the influenza vaccine. Across all populations, flu vaccination rates in Michigan fall below the national average. In fact, there are only a handful of states whose rates are worse than ours. Every year, about 20% of Americans get the flu. As many as 49,000 die of flu-related complications, and some 226,000 are hospitalized. This adds up to $10 billion in medical expenses and $16 billion in lost earnings. So here's what you can do. All your patients should get an annual flu shot between October 1st and March 31st, unless they're allergic to components of the vaccine. During the season, recommend a flu shot to all your patients. It's easy to talk to those that come in for a visit, but you should also run a search using your EMR registry and contact patients without a documented immunization. Ask them if they've been immunized somewhere else, and if so, enter the information into your registry. If they haven't, encourage them to come in and get a shot. If they refuse, document that too. The next preventive care and screening measure is for the pneumonia vaccine. An estimated 90% of pneumonia deaths happen in patients 65 and older. One shot at 65 years or older can dramatically reduce the chances of getting pneumonia. So it's worth it to talk with each of your patients who are 65 and older to see if they've had at least a dose of Pneumovox or Prevnar. You should also run a database query and call those patients who haven't gotten a vaccination and ask them to come in. The Journal of American Medicine finds that nearly 35% of Americans are obese. That's more than 78 million people, spending an estimated $147 billion in related medical care. That's because obesity can lead to heart disease, stroke, type 2 diabetes, and certain types of cancer. The third preventive measure is BMI screening and follow-up. Every patient who comes into your office should have their body mass index checked. That's your weight in proportion to your height. And that number should be charted every visit. What you're looking for are patients 65 and older with a BMI greater than 23 but less than 30, and those aged 18 to 64 with a range of 18.5 to 25. The only exception would be a pregnant woman. Weight problems aren't limited to those who are overweight. In the Medicare population, we're equally concerned with underweight populations. If a patient is out of range, CMS is looking for a documented follow-up plan. This means providing educational materials, nutritional supplements, or referrals to a dietitian, nutritionist, physical therapist, or exercise coach, someone who can help them maintain a healthy BMI. The exception for not getting a BMI for each patient is an immediate medical treatment is needed where a delay might jeopardize their health. If your patient refuses to step on the scale, jot that down, or if there are any other circumstances preventing you from getting a BMI, put it in their chart. Best practices we've learned are: adult BMI requires documentation of a plan for patients that are either overweight or underweight. It can be simple, such as recommending nutritional supplements and a recheck in 2 months. The next preventive health measure is tobacco use screening and cessation intervention. Smoking kills more than 480,000 Americans each year. 41,000 of those deaths are from secondhand smoke. And it costs the U.S. more than $300 billion a year in medical care and lost productivity. CMS wants you to talk with your patients who smoke about quitting. The Department of Health and Human Services finds those people who are advised to quit by their doctor are more successful in stopping to smoke. If your patient says they do smoke, even the smokeless cigarettes, give them information on cessation counseling or pharmacotherapy and make sure you chart it. If your patient won't tell you that they smoke or you weren't able to screen them, make sure you include unknown in their chart and loop back with them at their next appointment. The next CMS measure is depression screening and follow-up. Serious stuff in patients 12 and older. Up to 20% of U.S. adults older than 65 have had depression. That's 7 million adults. If your patient comes back positive on a standardized depression screening, you are required to develop and document a follow-up plan on the date of the positive screen. You also need to note the test used. Depression screenings must be reviewed and addressed in the office of the provider filing the code on the date of the visit. And the screening and the visit must happen on that same date. Your follow-up for patients with a positive screening must include at least one of the following: additional evaluation for depression, suicide risk assessment, referral to a practitioner qualified to diagnose and treat depression, medications, or other interventions or follow-ups for the diagnosis and treatment of depression. Next up, statin therapy for the prevention and treatment of cardiovascular disease. The measure reports the percentage of beneficiaries who were prescribed or were already on statin meds during the measurement year, and who fall into any of the following categories. High-risk adult patients 21 years or older who were previously diagnosed with or currently have atherosclerotic cardiovascular disease. Adults 21 years or older with any fasting or direct low-density lipoprotein cholesterol level that's greater than or equal to 190, or diabetic patients aged 40 to 75 years with a fasting or direct LDL-C level of 70 to 189. The measure contains multiple, equally weighted denominators to align with the updated clinical guidelines for cholesterol targets, and replaces the low-density lipid control measures recently retired from the measure set. The next domain to brush up on is care coordination. Today's healthcare world is hard enough for healthcare workers to navigate. From a patient's perspective, it can be even more confusing. In an effort to simplify a complex system, the Medicare Shared Savings Program has identified care coordination as a focus domain. Without someone tying up the loose ends, it could mean medication errors, preventable hospital readmissions, unnecessary pain and suffering for our patients, and huge costs. An estimated $240 billion by the Institute of Medicine. By communicating and coordinating care across the healthcare system, our patients can live healthier, longer lives. Of course, there can be lots of challenges that stand in your way, like prompt and effective communication between your practice and the hospital, poor patient compliance, an incomplete or out-of-date medication list, and difficulty coordinating care across various settings and multiple providers. One of the best things your office can do is implement a process for contacting patients recently discharged from the hospital. This process may include helping them schedule follow-up visits, tracking reports, providing education, and recommending resources. And when it comes to their medication list, it needs to be reviewed and documented by their physician or ancillary provider at each and every visit. Be sure to document and maintain those records of any patient contact related to care coordination activities. We know we're doing a great care coordination job when hospital admissions and readmissions are reduced. An additional important component of the care coordination domain is patient safety. It's up to all of us to make sure our patients are as safe as possible. A focus in the older patient population is their fall risk. Falls are the leading cause of fatal and non-fatal injuries in this population. Your patients 65 and older should be screened for their fall risks. Their risk is high if they've had 2 or more falls in the past year or any fall with an injury in the past year. If so, it's time to come up with a plan of care. It could include adaptation or modification of their home environment, withdrawal or minimization of psychoactive medication, withdrawal or minimization of other medications, managing of postural hypotension, management of foot problems and footwear, and exercise including balance, strength, and weight training. By just talking with our older patients and developing a care plan, we can help reduce the estimated 2.5 million falls each year. And the last domain is the patient experience. CMS has identified 7 focus areas to better the patient experience. They are response timeliness to appointment requests, office visits, and information requests, effectiveness of physician communication skills, the overall rating of the physician, access to specialists, effectiveness of health promotion and education, inclusion and shared decision-making, and information about the patient's personal health status. To see how UPACO practices are doing on these measures, a Consumer Assessment of Healthcare Providers and Systems, or CAP survey, for accountable care organizations is conducted each year. The ACO administers the survey and gets a hold of Medicare beneficiaries by mail or phone. The CAP survey is designed to help make great customer service a habit in your practice. Here's what the survey asks. In terms of timely care appointments and information, CAPS wants to know if patients were able to get an appointment as soon as they needed it, if they saw the provider within 15 minutes of their appointment time, and if they got timely answers to any questions they called about. There are lots of reasons your office might not get such a great score on this measure, such as a poorly coordinated process for patient check-in or workup, lack of appointment availability or last-minute provider schedule changes, or a lack of accountability and standards for responding to patient calls in a timely manner. What you can do is huddle. Take 5 minutes to meet with physicians and staff and talk about what's going on in the office that day and any special circumstances that could throw you off course. By communicating, everyone will be on the same page and able to navigate things more efficiently. And speaking of keeping everyone in the loop, the next CAPS measure is how well your doctor communicates. The survey wants to know if providers are clearly explaining things, listening carefully, showing respect, giving easy-to-understand instructions, if they know a patient's medical history, and if they spent enough time with the patient. Take note of these responses. Little changes in the way you interact with a patient can make a big difference in a positive experience, such as sitting down in the room with the patient, not allowing interruptions, not spending the visit looking at a computer, facing the patient, and actively listening and repeating back to the patient so they know you were listening. The next measure ties right into how well a doctor communicates. This one asks patients to rate their provider. It's a scale of 0, the worst, to 10, the best. Ensure top scores by optimizing your office's processes and using the suggestions provided to let your patients know that they are your top priority. The fourth measure is access to specialists. The survey wants to know how easy it is to get a specialist appointment and how often those specialists were aware of a patient's medical history. You can get a great score on this one by establishing specialist guidelines in your office. When possible, direct the patient to the most appropriate specialist. For example, if a patient needs a retinal specialist, don't refer to a general ophthalmologist first. Refer to physicians who communicate well with patients and other team members. And refer to physicians who practice cost-effective, high-quality care. When a patient goes with your recommendation, you're more likely to get the results and be a part of the follow-up. And you're more likely to get helpful patient information over to the physician prior to the appointment. The next measure is all about a healthy lifestyle and how you're doing on health promotion and education. Specifically, the question asks if during a patient's visit, were they informed about illness preventions, healthy diet and exercise, and health-related goals. The survey also wants to know if they were asked about their emotional well-being and any stressors in their life. Here's an easy way to get this in during an office visit. Give your patients prevention, nutrition, and exercise information to read or watch during their wait. It's a great idea to include health information on your website so when they're at home, they can reference it. When you do make any health-related recommendations, write it on a prescription. That way they'll perceive it as doctor's orders. And before they leave, ask them about their health goals and how you can help them reach them. By adding the simple phrase, "We are going to work together to," this will prompt your patient to remember that you engaged them in shared decision-making. The sixth question is about shared decision-making. The survey wants to know if you talked with them about their medications, reasons for surgery or a procedure, and about sharing health information with their family and friends. The first course of business here is to make sure your patients are aware of their medical condition and then involve them in the decision-making process. This will help them take some responsibility in finding other sources of information such as the internet, support groups, or community resources. The next question is a checkup on your patient. CAPS wants to know the overall mental and physical health. It asks about the cognitive and functional status and about any chronic conditions. And the last survey question is stewardship of patient resources. CAPS wants to know if you've talked with your patients about prescription medication costs. At each visit, review their medication list. Encourage them to let you know if they're having trouble affording anything on that list. If so, recommend a less expensive alternative if appropriate. The CAP survey is done every November through February and may help you identify some areas of opportunity, such as the need to hire more service-savvy people, establish a higher standard of customer service, help staff better hear the voice of the patient, remove barriers so staff can serve patients, reduce anxiety to change, help staff better cope in a stressful atmosphere, and maintain a service focus. These opportunities may require just a small tweak in your office, others a substantial process change. You may get pushback from some employees, while others are in it from the get-go. A great way to get everyone's buy-in is to encourage communication, engagement, and participation. Look for ways employees can take ownership. Ease into the change. Make small moves rather than jumping in all at once. This gives employees time to accept what's going on and also gives you the chance to refine the process. And remember that any change or improvement is an iterative process. Chances are you'll be making refinements along the way. And some overall next practices we've learned along the way. Initial Medicare visits, annual wellness visits, continue to be extremely important for alignment of beneficiaries, diagnosis capture, and completion of screening measures. Please contact your physician organization if you would like assistance in improving annual wellness visit rates. Snowbirds pose a challenge. Consider developing a travel packet for your patients that head south during the winter months. That includes summary of current care items, including medical conditions and medications. And include release of information forms for services such as labs, preventive screenings, and immunizations that may be obtained while they're out of state. If you have any questions or ideas, our UP ACO team is always interested in what you have to say. Please contact United Physicians at 248-593-0100.